ఇది కొట్టండి సార్ ఇక్కడ షేర్ స్క్రీన్ షేర్ షేర్ అవుతుంది.
అటెండెన్స్ తీసుకున్నాం.
55 నాకు
సరే.
స్లైడ్ షో పెట్టండి. తీసుకుంటాం సార్.
ఏదో నెంబర్ వస్తున్నట్టు కదా, అమ్మాయి తీసుకుంటాం.
157 వచ్చారు సార్. సార్ అడిగి తీసుకుంటాం.
ఎవరెవరు వచ్చారో రికార్డ్ అవుతుంది అనుకుంటా. అమ్మాయికి ఫోన్ చేసుకొని కొంచెం ఎన్నిటి తీయాలి, కార్డు తీయాలి. హలో హలో, గుడ్ మార్నింగ్.
Good morning, sir.
Am I audible to you?
Yes, sir.
Okay, I am Dr.S.Nagamuneiah. The first class will begin today. So I have been allotted 4 chapters. First we will start with the testis and scrotum chapter. So if I am not audible or any problem, you can tell it to me, okay? Just we have a brief review of the anatomy and histology of the testis. So the testis, I, if you use I, it is singular. If you use E, it is plural. Testis is a male gland in the mammals or the animals, which is equivalent of the ovary in woman. So male generative organ is the testis and female generative organ is the ovary. The testis produces, the function of the testis is 2 things. One is production of the sperm for fertilization and propagation of the race. And another one is testosterone, production of the hormone testosterone, which will give the maleness to the person and which will also have many metabolic functions. Not only the maleness, it has got many metabolic functions. Testosterone, very useful for maintenance of the bone strength. How and when the testis develops? In the intrauterine life, testis develops around 4th to 6th week by the thickening of the peritoneum, which covers the mesoderm, intermediate mesoderm.
చందన తీసుకుంటారు
స్క్రీన్ షాట్ కొట్టుకొని తీసేసుకుంటాం.
Sorry. At the intermediate mesoderm, at the level of the developing kidney. So the kidney develops at a lower level, the metanephros, the third stage of the kidney development occurs at a lower level in the pelvis. Kidney ascends, whereas the testis develops at a higher level and it descends outside the body. This thickening of the peritoneum is called as genital ridge, which forms the testis, and this only contains the half of the testis. That means the capsule, the tunica albuginea, the mediastinum of the testis, which is a thickened part of the tunica albuginea. From this thickened part, the septa will descend into the cavity of the tunica albuginea, dividing it into number of compartments. And these compartments have got the seminiferous tubules, which develop from the sex cords. The cells which proliferate from the genital ridge, they fill the compartments, forming tubules which are called as seminiferous tubules. These seminiferous tubules only contain the Sertoli cells and interstitial leading cells. No genital cells are there, no gonadal cells are there. These gonadal cells, they develop at a different part of the embryo, where the primitive streak fuses or meets the yolk sac. At the junction of the yolk sac and the primitive streak, which is present in the lower part of the embryo below the notochord. Notochord gives the development of the spinal cord. Below that, the primitive streak develops the urogenital systems. From that point, along the wall of the yolk sac, they reach the developing bowel, intestine. From the intestinal wall, they migrate into the mesentery of the intestine. From the mesentery, they travel down deep into the retroperitoneum, reach the genital ridge area, and enters the developing testis. So the genital cells, gonadal cells, they develop at a different point. They migrate a long distance and reach the developing testis. So they take the habitat, they take the refuse in the developing kidney for nourishment and for their development. This is how the testis develops. The structure of the testis develops locally in the genital ridge, in the lumbar region, having its blood supply, nerve supply, lymphatic drainage, venous drainage, all those things. But the gonadal cells, they migrate from a distant part and fill the seminiferous tubules, and they take refuge here. They take nourishment from the Sertoli cells and begin to develop after a long time, at the time of the puberty. Till that time, they remain dormant. In this picture, you can see the cells are migrating along the bowel wall through the mesentery into the area of the genital ridge. This green thing is intermediate mesoderm. Thickening of the part of the intermediate mesoderm gives rise to genital ridge, which is developing into sex cords or compartments of the testis. The red dots are the gonadal cells coming from a different point. Once the testis develops, the testis has to descend, because the function of the testis is dependent on the temperature of the testis. So the enzymes which are helpful for the maturation and development of the spermatogonia and the spermatids, the semen, needs a lower temperature than the body temperature. So for this purpose, the testis has to descend. As it develops during the embryonic period, slowly it comes down, and through the inguinal canal, through the abdominal wall muscles, it passes out of the abdomen into the final destination of the scrotum. This is thought to be helped by a fibrous process called as gubernaculum. Gubernaculum. So it is thought only, it's not proved yet. A gubernaculum is supposed to help the pull down the testis from the lumbar region into the scrotum. The descent of the testis begins at the 7th week of life. At the internal ring, it reaches the internal ring at 3 months of gestation. The first trimester is over. By the time the first trimester is over, the testis has reached the site of the internal ring. And from 7th to 9th months, it reaches the scrotum. During the intervening period, it traverses the muscles, among the muscles, making the inguinal canal to develop and comes out just before birth. The left testis descends early in the intrauterine life. The right testis develops just after birth within 3 months. If you examine the neonate, infant or neonate, in 97% of full-term children, you see both the testes in the scrotum. Whereas in preterm babies, in only 70% you see the testis in the both testis in the scrotum. So by the age of 3 months, both the testes have reached the scrotal region. Left testis descends early and right testis descends a little late. This is thought to be one of the cause for more common incidence of hernia on the right side. This is how the testis is pulled down by the gubernaculum from the inguinal region, lumbar region to the scrotal region. The mechanisms are poorly understood. One mechanism is the presence of gubernaculum testis, and the hormones also which help for descent of the testis are Mullerian inhibiting substance and maternal chorionic gonadotrophin. These things are thought to be helpful in the descent of the testis. Coming to examination of the testis, testis is a vertically oval shaped structure. Vertically oval structure, 3 to 4 centimeters in size, smooth surface one, firm in consistency. If you feel the testis, it feels firm. And posteriorly, the testis is attached by the epididymis, which is a long tubular structure. Epididymis is a long tubular structure closely adherent to the testis, posterior aspect of the testis. And the testis is surrounded by the tunica vaginalis. Tunica is another covering. Tunica albuginea is the first covering which packs the testicular substance. Over that, you have got another layer which is derived from the peritoneum, that is called as tunica vaginalis. And between these two layers, tunica albuginea and tunica vaginalis, you have got a potential space, not real space, potential space. Through this narrow potential space, the fluid which is secreted from the testicular substance and the tunica albuginea gets absorbed by the parietal layer of the tunica vaginalis. If some abnormality happens here, the fluid accumulates in this potential space, making it into a real space, which we call it as hydrocele. And the testis hangs down from the cord. At the upper pole of the testis, the spermatic cord will be present, attaching to the testis. Coming to the supply of the testis is supplied by paired testicular arteries from the front of abdominal aorta at the lumbar level. At T10 level, aorta gives off two midline branches, two arteries in the midline, which are called as the genital arteries or testicular arteries. Genital means in the male we call them as testicular arteries, in the woman we call them as ovarian arteries. Apart from this main supply, testicular artery, we have got collateral supply also. In the cremasteric fascia, you have a small artery which is a branch of the inferior epigastric artery, which gives rise to the collaterals to the lowermost part of the testicular artery. Another one is artery which accompanies the vas deferens, which is a branch of inferior vesical artery coming from internal iliac. So testis has got three sources of blood supply. One is the main artery coming from the aorta itself. Cremasteric artery is coming from the inferior epigastric, which is a branch of the external iliac artery. And artery to the vas, which is coming from the internal iliac artery. So all the major vessels in that region tries to supply the testis. Then the scrotum, the covering of the testis, scrotal layers are supplied by the internal pudendal artery coming from internal iliac artery. Internal pudendal, which passes through the Alcock's canal through the squarectal fossa and supply the perineum, also supply the scrotum. So in this picture, you can see the 3 arteries which supply the testis. You can see the main artery which is coiled and larger in size, the testicular artery, a small branch accompanying the vas deferens, and the cremasteric artery coming down and having collaterals here. Again, venous drainage. The veins also drains in the retroperitoneum into the major veins. They travel along the testicular artery, gonadal artery above, and drain into the main veins in the lumbar region. The right testicular artery drains directly into the inferior vena cava. Because the testicular artery arises from the aorta, naturally the vein also has to drain into the inferior vena cava, its corresponding vein. On the left side, the left renal vein enters into left gonadal vein enters into the left renal vein. The peculiarity of this vein is the left vein enters directly into the left renal vein at right angles. So if there is any obstruction to the flow of the left renal vein, the rise to pressure will be transmitted into the gonadal vein, helping to development of the varicosities of the testicular veins. That is the one reason of why the varicocele is more common on the left side veins. This anatomical peculiarity where the gonadal vein enters directly into the left renal vein at right angles. And further, it has got no valves. At the junction of the renal vein and the gonadal vein, there is no valve. So any rise in pressure of the renal vein is easily transmitted into the gonadal veins. And another peculiarity of this venous drainage is close to the testis, in the spermatic cord, in the inguinal canal region, the veins they surround the testicular artery. So in this picture, you can clearly see the testicular artery is coiled and surrounded by a number of veins. Why this arrangement is made? Because to cool the blood coming to the testis. Testis needs a lower temperature than the body for its function. So if the blood is coming directly from the aorta, which is at a body temperature, so it has to be cooled before it reaches the testis. So as soon as the testicular artery comes into the parietis of the inguinal canal, it will be surrounded by a plexus of veins which will take the temperature of the blood in the artery and cools it. That is the arrangement. Next important thing is lymphatic drainage. Because the testis develops in the lumbar region, it draws its blood supply, it drains into the veins in the lumbar region, and the lymphatics also it drains into the lumbar region. So the lymphatic drains into the lumbar lymph nodes, pre-aortic, para-aortic lymph nodes in the lumbar region at L1 level. Any disease which affects the testis, you must examine the abdomen, epigastrium, for development of the lumbar lymph nodes, because the original lymphatic drainage of the testis goes to the lumbar region. Second thing is the covering, the scrotum. The scrotal lymphatics, they usually drain into the inguinal region, inguinal lymph nodes. So though they are at the same place, their origin of the testis, origin of the scrotum is different. Everything, their blood supply, lymphatic drainage is also different. So this is also of some clinical importance. Drainage of the lymphatics, we will see later. The narrow supply to the testis comes from the lumbar region again. T11 and T12 segments, they supply the testis. Structure of the testis, already I told you, it's a vertically woven structure bag having a thick tunica albuginea, having septa coming from the covering, divided into number of compartments. And these compartments are filled by the seminiferous tubules. And these tubules are invaded by the gonadal cells. They harbor the gonadal cells. They nourish the gonadal cells for the development. Mediastinum of the testis. This is the place where the tunica albuginea is thickened like a sandy dune, a little thickening, from which the septa will begin and divide the cavity into compartments. That region of fibrous tissue or mesodermal tissue is called as the mediastinum of the testis, from which the arteries, the nerves, the veins, the lymphatics, everything will enter into the substance of the kidney. If the mediastinum is compressed, if the mediastinum is destroyed, along with it, the nerves, lymphatics, and arteries are also destroyed. So the diseases which invade this mediastinum of the testis, like the tumors, like the gamma of due to syphilis, they will destroy these nerves and the testicular sensation will be typically lost. Why testicular sensation is lost in these diseases means they compress the mediastinum and damage the nerve fibrils which are present in the mediastinum. Then rete testis, the tubules which enter into the epididymal head of the epididymis from the testicular substance. The collection of these tuminiferous tubules which traverse the mediastinum of the testis to join the epididymis are called as rete testis. So rete testis pronounces the seminiferous tubules. Mediastinum pronounces the mesodermal part of the capsule. The point, just like the hilum. You can call it as hilum of the testis, from where the septa will begin, through which the artery, nerve, veins will enter into the substance of the testis. So these tubules are called as, different tubules are called as rete testis. And this black thing, this thickening of this one is mediastinum. This substance is mediastinum. From the mediastinum, the septa are descending to divide the testis into compartments. In between the septa in the compartment, you have got the number of seminiferous tubules. Entire thing is covered by the tunica albuginea, which is covered by the parietal layer of the tunica vaginalis. The cell types that are present in the testis are, of course, you have got seminiferous tubules. In the seminiferous tubules, you have got the gonadal cells or germ cells, which are also called as primordial gonadal cells. Primordial means very old, ancient, in the beginning, Adi. The beginning, old primal germ cells. They travel and get lodged in the seminiferous tubules. They divide to develop the spermatogonia. So when the cell divides, one cell remains as the basal cell, reserve cell. Another cell will differentiate into the spermatogonia so that the number of gonadal cells will remain constant. The spermatogonia will mature into spermatocytes, primary and secondary spermatocytes, which further matures into spermatid and spermatozoa finally. As the maturation goes, the shape of the cell will alter and the meiosis will occur and the chromosome number will reduce to half and it will have only one sex chromosome, either X or the Y. So by this time it reaches to the spermatozoon, the shape will be altered. It has become mobile, individually mobile by development of the tail, and the chromosome number has decreased to half, and it will harbor only one sex chromosome, either X or Y. All these changes will occur in the process of the spermatogenesis. This is the main type of cell that is important in the testis. Another nourishing cell is Sertoli cell. This is the main cell of the epithelium of the seminiferous tubule, which is a large cell, which number of branches. To the branches, these gonadal cells will be adherent and they receive the nourishment and nutrition from the Sertoli cells. Sertoli cells feeds the gonadal cells. It will have number of processes, just like the teats of an animal, of a cow or an animal, which feeds its children by milking. So these gonadal cells will be adherent to the Sertoli cell and gets nourishment, draw nourishment from the Sertoli cell. That is the main function of this cell. Another cells called as Leydig cells, which are present outside the seminiferous tubules, in between the seminiferous tubules in the interstitium, which are called as interstitial cells or Leydig cells. They secrete testosterone and other androgens. These are the secretory cells which secrete testosterone. In hyperplasia of the Leydig cells, the child becomes Hercules-like, infantile Hercules. Because of the oversecreted testosterone, the body grows very much and stouter. Then coming to the size of the testis, already we told it is around 3 to 4 centimeters or 2 inches, 5 centimeters in size, 0.8 inches in breadth, 1.2 inches in height, or 5 into 2 into 3 centimeters. The volume of the testis is on average 15 to 25 ml. You can calculate the volume of the testis by doing the ultrasound examination, which comes to 15 to 25 ml. Now, disposition of the testis is in the scrotum. It lie of the testis is vertical or horizontal. Usually it will be vertically oval. Sometimes it will lie horizontally oval. If it lies horizontally oval, it predisposes for the torsion of the testis. That we will discuss later. Now the version of the testis. This is relation of the testis to the epididymis. Normally, if you see, the epididymis will be posterior to the testis. Testis will be anterior. So this is called as retroverted testis. Retroverted means epididymis is posterior. Sometimes it will be anterior. Epididymis anterior means antiverted testis. Normal lie is vertical, retroverted is the position of the testis in the scrotum. Size of the testis is 5 centimeters. How do you measure the size of the testis? So this can be compared, the size of the testis can be compared with the available oval balls called as archidometer and determine the size of the testis. And this archidometer will tell you whether the size of the testis is corresponding with the age of the boy or not. You can compare the size, you can compare the development of the testis according to the age of the person. So this is called as Prader's archidometer. Prader's archidometer. You can compare the size of the testis with the balls in this chain, and you can compare the size of the testis to the age of the person also. Consistency will be firm in consistency, and testis will have a peculiar sensation. If you gently press on the testis, patient will not be able to describe what he is feeling, but he changes his face into a sick feeling. So that is called as testicular sensation, a peculiar sickening sensation which cannot be described by anybody. Only you have to observe the face of the person and see whether there is sensation is there or not. Peculiar sickening sensation. This is lost in diseases which press on the mediastinum of the testis. So this picture shows the background with dots, blue dots, violet dots is the Sertoli cell, onto which the gonadal cells are adhering. These are the primordial gonadal cells. As they divide, they metamorphosed into primary spermatocyte, secondary spermatocyte, spermatids. The final stage will be spermatozoa, which have become mobile because of the development of the tail. With this background, now we will come to discuss the common diseases of the testis. The first and important one is regarding the descent of the testis. Imperfect descent of the testis. The descent is not perfect. It is somehow abnormal. What are these abnormalities? Two types are recognized. One is incomplete descent. The testis is traveling in this natural pathway, but it has stopped before reaching the targeted site. Before reaching the scrotum, its destined site, it has stopped somewhere in the normal pathway. This is called as incomplete descent. Another one is called as mal-descent. It has come out of the pathway. It is an abnormal pathway. This is called as mal-descent. So incomplete descent is, say, normal pathway. It has stopped before reaching the scrotum. So the testis might have stopped in the abdominal cavity close to the inguinal ring, deep inguinal ring in the extraperitoneum. That is the first station where the testis is stopped. Second, it gets stopped in the inguinal canal. It has crossed the first obstacle. The first checkpost is the internal ring. So it has crossed the first checkpost and entered the internal ring. There it has stopped. The second checkpost is external ring. Checkpost means the testis encounter some difficulty to pass these narrow openings. So the second checkpost is superficial inguinal ring or external ring. Once it crosses the second checkpost also, it has to reach the bottom of the testis. Or it might have just crossed the external ring and is residing at the root of the scrotum. That is also abnormal, high-lying testis. The normal position of the testis is the midpoint of the testis should be a little below the midpoint of the scrotum. That is the normal position. Midpoint of the testis should be little below the midpoint of the scrotum. That is the normal position. If it is a little above but has crossed the superficial ring, this is called as high-lying testis. It has reached the scrotum almost, but a little at a higher point. So these are the points where the testis halts in incomplete descent in the normal pathway. And another point you should remember is this incomplete descent is testis is always immature. Why the testis has not descended means because it is immature. Because it has not descended, it does not become immature. Because it is immature, so the traveling of the testis is also halted at some point. Second thing is small descent. Here, the testis is fully developed. It is mature. Testis is mature. But it has crossed the limits and entered into a different pathway. It is present in a different places. Which place it will be traveling away is determined by the many-tailed theory of gubernaculum. Many-tailed gubernaculum theory of Lockwood. The upper end of the gubernaculum is attached to the lower pole of the testis to pull it down. For better anchorage of the gubernaculum, the lower end of the gubernaculum is divided into number of tails. Each tail will be taking footage at a different point. So if you observe the current poles or the telephone poles, at the top it will be a single point. At the base, for better anchorage to the earth, it will have number of points, number of limbs. So just like that, the gubernaculum at the upper end will have a single point attaching to the testis. The base, it will have many tails which take anchorage from the different regions of the body. So if the testis travels along with one of these anchoring limbs, it will reach to a different point rather than the testis. So the common positions where the mild descended testis reach is the commonest is the superficial fascia of the anterior abdominal wall, called as superficial inguinal pouch. Superficial inguinal pouch of Dennis Brown. Second, at the root of the penis. Third one is in the mid perineum. Third one. Fourth one is in the femoral triangle. So in all these places, the mild descended mature testis can lie, which is called as ectopic testis. It is present at an ectopic site rather than the normal scrotal site. The differences between incomplete ectopic testis are: incomplete testis is arrested in a normal pathway, it is immature, it is associated with hernia, and it is prone for malignancy. Seminoma will develop more commonly in the incompletely descended testis. Ectopic testis is descended abnormally to ectopic sites. It is fully mature, fully functioning, and it is prone for trauma. The only problem with ectopic testis is because of its position, it is prone for trauma. Otherwise, it is normal. The incidence is, if you take the incidence at birth, it is 4%. And during the first 3 months, if there is any incomplete descent of the testis, it will be completed. So if you take the incidence at the age of 1 year of the child, the incidence comes to 1%. 3% of the cases, the testis descends after birth. How to detect this? How to detect the presence of the incomplete descended testis? During the routine neonatal examination by the pediatrician, they will usually examine the scrotum also in male children for the presence of the testis. So it will be detected. If it is missed at this point, it will present during puberty. School health examination. School health examination also will detect some cases of incompletely descended testis. If it is escaped during all these routine examinations, it may present in adulthood with a hernia. Patient comes with hernia, inguinal hernia. And when you examine the scrotum, you do not find the testis in the scrotum, imperfectly developed scrotum. Then you must suspect it is a case of incomplete descent with a hernia. And some people, especially when the testis is in the inguinal canal, they develop torsion of the testis. The testis is not anchored properly in the inguinal canal, so it is more likely to get torted, more likely to get twisted on its own, geoparalyzing the blood supply and testis being necrosed. Patient presents with acute inflammatory signs, inflammation in the inguinal region. When you examine, you do not find the testis in the scrotum. There will be a tender inflammatory mass in the inguinal canal. If you do the ultrasound examination, it will show you the gangrenous testis. Next, family history. In 10% of the cases, positive family history will be present. In such cases, you must carefully examine the child to determine whether it is having the incompletely descent testis or not. So coming to the pathology, macroscopically it appears normal in the early childhood, except for the position, variable in the position, the size, the firmness of the testis will be normal during childhood. As the child grows, normally the testis also, all the organs of the bodies also has to grow along with the age of the person. So here, as the child grows, the testis will not grow according to the age of the person. So at puberty, the testis will be smaller than usual size. It will be more softer than the usual firmness. So during childhood, only the position is abnormal. At the time of the puberty, the position is abnormal and the consistency, size of the testis will also be abnormal. And if you see the microscopic picture, which becomes apparent from 1 to 2 years, after the 2 years, by the age the child reaches 2 years, the microscopic histological damage is already in progress. That's why if you want to correct the position of the testis, it has to be done before 2 years of age. That was the dictum. After that, already the testicular substance is damaged. No benefit will be gained from doing the operation at a later period. There will be loss of the Leydig cells, which secrete the testosterone. Degeneration of the Sertoli cells. So no nourishment for the sperm if they are present. Decreased spermatogenesis. So all the cells of the testes which are temperature dependent, they become degenerated if the testis is there in abnormal position for more than 2 years. The higher the testis, the greater the degree of histological change, because the greater will be the temperature of the testis, the greater will be the degree of histological change. So these are the microscopic changes you see in the undescended testis after 1 to 2 years of age. The consequences of this small descent or undescended testis, they are infertility, the malignancy, hernia, and torsion. These are the 4 complications of the undescended testis. The foremost is the infertility. This is a well-recognized consequence. The paternity rates, the capacity to father a child is decreased to 2/3 of the normal in unilateral undescended testis. It is decreased to 1/3 of the normal for bilateral cases. So definitely the paternity rate is decreased. The fertility of the male person is decreased by having the undescended testis. Now the question is, can you able to correct this deficiency if you do surgery? So it is found that even if you do the orchidopexy, bring down the testes as early as possible, the benefit is questionable. The benefit is questionable. Already I said the is testis has not descended because it is immature. Its development has not been completed. That's why it has halted at a higher place. So the main problem here is immaturity of the testis, not the transport of the testis. So by aiding the transport, even if you bring the testis down, it will not get mature. So there is no guarantee that orchidopexy or early surgery will definitely benefit the person. There may be some benefit in the form of development of the Leydig cells and hormone secretion, but fertility rates may not be rising. The second one is malignancy. So these people, the undescended testis is 5 to 10 times at greater risk for development of malignancies, that is seminoma. Seminoma develops more commonly. Again, early orchidopexy is of doubtful benefit. The only benefit is it makes the testis easily identifiable because it is outside the body in the scrotum. If the tumor develops on routine examination, you can easily identify the tumor in the testis at early stage and treat the person. That's the only advantage you get by doing the early orchidopexy. Always it is associated with hernia because the processus vaginalis, which should get obliterated. If the testis reaches the scrotum, the purpose is over and the processus vaginalis will be obliterated. Because the testis has a halt at a higher point, the processus vaginalis will not get obliterated and remains patent, and it is easy for the intestine to enter into a patent sac, already present sac. So this is the cause for the hernia. Though it is said that in 90% the process is patent, clinically less number of cases are identified. Then testicular is prone for testicular torsion because it is not anchored properly. That is another complication of the undescended testis. Critical features, if you see the child, the corresponding scrotum will be underdeveloped. There is no testis occupying the scrotum, so the scrotal skin will be crumpled, it will be smaller in size, underdeveloped. The undescended testis can be unilateral or bilateral. The right side, which is 50%, left side 30%, bilateral cases are 20%, more common on the right side. One important thing while examining a child with undescended testis is you must determine whether it is a true undescended testis or whether it is a retractile testis. In children, the cremasteric reflex will be very active. The purpose of the cremaster muscle is whenever the body sees there is some danger to the testis, some injury is going to occur to the testis, the cremaster pulls up the testis close to the body and tries to protect it. That is the function of the cremasteric reflex. In children, this will be more active. If you tries to see by opening the underwear of the child, if you tries to see the perineum, so the cremasteric reflex gets activated. Or if you touch the medial side of the thigh, it gets activated and cremaster pulls the testis upwards. By the time you see, the testis will be at a higher place. Even it might have entered into the inguinal canal also in some cases. Such things are called as retractile testis. And when the child relaxes, again spontaneously it comes down into the scrotum. So this has to be determined before pronouncing the treatment to the patient. Second point is, if you do not see the testis in the scrotum, then you have to search for the testis. First, search the testis in the superficial inguinal pouch for the retractile testis. Then feel the inguinal canal for the testis. If you do not find the testis on clinical examination, then do the ultrasound examination to locate the testis in the canal or at the internal ring in the retroperitoneal tissues, extraperitoneal tissues. Even if you do not see by ultrasound, then you have to go for laparoscopy and examine the peritoneal cavity, posterior wall of the abdomen, along the path of descent of the testis for any rudimentary testis, presence of the testis. This is how you have to search for the testis. Retractile testis has to be differentiated from the undescended testis. The differences are undescended testis is less common than the retractile testis. You have got underdeveloped scrotum, and even if you pull the testis from the inguinal canal, you cannot bring it down into the scrotum. So, 2 minutes. Even if you pull it down, you cannot bring it into the scrotum, and it is immature. Retractile testis is more common. Scrotum will be normal. You can pull it down with manipulation. It is more mature testis, and child testis positive. If you make the child sit like this in a chair, because of the rise in the intra-abdominal pressure, the testis comes down to the scrotum. This is called as or chair test. Bilateral undescended testis is called as cryptorchidism. Cryptorchidism means hidden testis. This is on both sides. So laparoscopy, if you do laparoscopy, you can see the testicular mass in the extraperitoneal tissue. Here it is at the internal ring. What to do with it? Before the testis undergoes histological changes, if you can bring it down, there may be some benefit. So originally it was thought it should be, they said it should be operated before 2 years, but now the age of the child has been decreased. It should be done before 12 months of the age. If you do not see a testis in the scrotum, you wait up to 6 months and allow the testis to come down spontaneously. If it does not come down even after 6 months, and if the child can tolerate the surgery, it is the time for operating on the child and bring it down. So to bring the testis down, you need to lengthen the spermatic cord. The cord can be lengthened by 3 maneuvers, that is, isolating and dividing the process of vaginalis if it is present, and divide all the coverings of the cord, external spermatic fascia, cremasteric spermatic fascia, and any fibrous bands are there, laterally you cut them. All these maneuvers will lengthen the spermatic cord, which aids to bring the testis down. And testis has to be fixed in the scrotum, in the subdartos pouch, and not to and allowing to be there and preventing it to get retracted by itself. If you fail to bring it down at the single sitting, you can do it in 2 stages. First, as far as possible, you mobilize the testis, fix it at that point, wait for 6 months or 1 year, then again try a second procedure to bring the testis down into the scrotum. That may be successful after some time. If this is also not possible, the procedure is done that is called as Fowler-Stephens method, where the gonadal artery is ligated a little above the testis. And testis survives by the collaterals of the vas deferens collaterals from the cremastic artery. Allow sometimes 6 months or 1 year, during which period the collaterals will develop much and testis survives. Then you bring it down to the scrotum. This is called as Fowler-Stephens method of correcting the testicular descent. If nothing can be done, testis is very atrophic, patient is at puberty, other side it is normal. In such cases, to avoid the danger of malignancy, we can explain and do the orchidectomy. Atrophic testis is no more use and it has got the danger of developing malignancy, so you can remove it. And you can put some scrotal implant. Implants are available for cosmetic purposes. You can put a silicone implant of similar size in the scrotum. So for looking that the scrotum looks normal, that can be done. So ectopic testis, all the 4 positions I told you, it is very mature, except for the predisposition for trauma, it does not require any treatment. These are the positions of ectopic testis. So thank you, and next class we will talk about the other disease of the testis. I think you have got some other class now. Thank you very much. Okay. Whatever attendance I now.
Chandana screenshot.